We got people jumping on now.
I'm surprised so many people are webinared out because we've been on so many coronavirus webinars. So we've got webinar fatigue, I think.
Good to have a little change of topic, I guess.
Hello, everyone. If you're on the line, I'd like to welcome you to the TIPS Masterclass webinar, first of 3 webinars to address surface contamination and transmission. Your lines are muted, so we cannot hear you, but we will get started in just a few minutes. Good morning, everyone. Welcome to the TIPS Masterclass webinar. This is the first webinar of a series of 3 to address surface contamination and transmission. My name is Dr. Christine Green. I'm president of the HITS Consortium and board member of the Infection Prevention Strategy. Today we'll be hearing from Dr. Ruth Carrico, who will be presenting on c.diff, new trends and prevention strategies. This is the first of our 3 webinars that'll address the new trends and strategies for healthcare-associated infections. We will get started in just a few moments as we see that more and more people who are joining us. Your lines are muted.
And then focus on some of our new prevention approaches including how we rethink the whole issue of this disease, that we're realizing as it changes, if we're going to stay current and do our responsibility protecting patients, we're going to have to change too. So what I hope to accomplish in our short time together is to talk a bit about the changing epidemiology of C. diff. And that includes not only what we are seeing in hospitals, in long-term care facilities, but also in the community. I want to focus a bit on some of the approaches that we are considering about that brings kind of some new terminology to this discussion, and that is one of diagnostic stewardship. And that is how we identify, when we identify, under what circumstances we identify this organism, and then what does it lead to with respect to our collaborative approaches. Then we'll end by looking at this with an eye towards some very specific control strategies that impact not only how we deal with prevention of the organism itself, but prevention of how that organism can be acquired and the impact of the environment in many of those approaches. And then recognize this is a tremendous and a very distinct demonstration of our commitment to patient safety. I want to extend an appreciation also to Pfizer Pharmaceuticals that enables us to look at the study of this, and we are looking at this across the entire community of Louisville as a full-fledged epidemiologic study. So we hope that we are going to be able to provide new information to the universe of knowledge as we all work together to do this. So as just an opportunity for disclosure, I want to appreciate that, appreciate their support. Many of us have seen this picture in the past. This showed really, we use this when we first began to recognize the importance of C. difficile as a problem specifically in hospitals. And although this slide shows what we have come to recognize as occurring over the last 20 years, it still is very representative that this remains a problem in all healthcare settings. We look at the importance in the number of cases in hospitals where we see both acquisition and transmission occurring in hospitals, but also what happens when individuals acquire this illness and they return home, that it is not ending at that point, that the problems with infection and the consequences, both financial and in terms of just the human toll of this infection, continues well beyond wherever that organism is acquired and wherever the disease is identified. When we look at long-term care, and in this slide, remember 20 years ago, we were still calling long-term care nursing home. Now we know that the industry itself is changing in response to this rapidly increasing demographic. But the number of cases that we still see in long-term care are problematic, and we are recognizing that more and more as a place where long-term care has is really where we are seeing the impact of antimicrobial stewardship, the good points and the bad points that are happening in hospitals. Then as patients are in long-term care facilities, they have a whole other set of issues that we are recognizing, and that problem with ongoing acquisition and transmission continues in across the entire healthcare continuum. So where are we now with the present? What are we learning about C. difficile? Well, the first thing we're learning is it's got a new name. It has been reclassified somewhat, so now we don't think of it as a Clostridium organism. It's got its own name now, Clostridioides difficile. So fortunately, the C stayed the same, so we still think of it and call it C. difficile, and still look at infection as CDI. C. difficile infection. We know it's a leading cause of healthcare-associated infections in the United States, and it's accounting for 15 to 25% of healthcare-associated diarrhea in all healthcare settings. And we're seeing then the continued impact in terms of loss of life. Acquisition, and we're really looking at acquisition of C. difficile and recognizing that you may acquire the organism at some point, but we may not see the impact of infection till weeks, months, perhaps years later. So looking at how care is delivered across all healthcare settings with an eye of how we can prevent transmission of this organism has become important. And we know then that our responsibility for taking action and providing a standard approach to safe care, both in terms of environmental disinfection and control, as well as general care practices and antimicrobial use, has never been recognized more widely than it is now. We know that when someone becomes ill, there is a significant burden, both in terms of the length of stay, readmission rates, and costs. And some of our cost data are quite significant, $10,000 to $20,000 per case, and the impact on healthcare costs nationally, as you can see, are tremendous. I added this information, I think it's just come out recently, and I put the citation at the end of the slides, but there was a recent meta-analysis looking at c. difficile and using then data that are available across and through a number of studies and across a number of data sources. Tells us that c. difficile currently accounts for 15% of all healthcare associated infections. Remember, previously I said healthcare associated diarrhea, but now we're looking at, while this is 15% of all HAIs in the United States, this is huge. The increase in the mean length of stay is anywhere from 3 to 21, almost 22 days. And then looking at then incident rates, 8.3 cases per 10,000 patient days. So this is not an infection that we need to be taking lightly. So that means we need to be looking not only at the treatment of c. difficile, but we need to be well enchanted upstream. And that is, how we prevent the organism from even being part of an individual's microbiome. The CDC has said this is an urgent health threat. We looked at now, we are seeing individuals that are presenting to healthcare after acquisition or the onset of this infection occurring in the community. And when we try to look at risk factors and try to determine where might acquisition of this infection have occurred, we're unable to find the links to healthcare. So this is, again, not only a head scratcher in terms of how are we going to fix this problem, but it shows us that we still have much to understand. We know that there is a strong community risk, community onset, community association, and therefore we're going to have to look outside healthcare facilities. We also have challenges with testing, that we know the tests and the testing processes are sometimes lend themselves to confusion in us understanding what is happening with the organism and is recognizing the organism distinctly different from recognizing c. difficile infection. Some people erroneously think those two things are the same. Well, they clearly are not, and we'll talk about this in our upcoming slides. But I think it's helpful to just do some level setting with our group so that we all understand a bit about the pathogenesis. This is an organism that is fecal oral. That means we ingest the organism. It then becomes part of our GI microbiome. Once it is in the colon, then all kinds of things begin to happen, and very few of them are good. If we look at it at this point, then we see that in this cartoon, I try to depict then the colon cells that you can see as the tall columnar orange cells, the plethora of organisms in our gut are the rods and cocci that we see, just a mini gram-positive, gram-negative, thousands and thousands of different organisms. At the bottom, we see the bloodstream with some of the yellow soldiers, our immune system soldiers, our white blood cells that are in our bloodstream just on the hunt for problems. When we provide antibiotics to an individual, we change then their microbiome. We get rid of targeted organisms. We also have collateral damage. Some that we hoped were not going to be impacted are impacted, and therefore we begin to remove then some of the crowd that is present in our gut, and then we leave opportunities for organisms then to emerge as a primary player, as we see in this third cartoon, where now we have C. difficile can become a dominant organism. We see the production of toxin as is represented by the red stars. Now we have then toxins that begin to destroy the colon cells. This is a target then for those soldiers that are in our bloodstream. Now we see white blood cells come into the area to try to lend assistance and see what is happening. We see then in this fourth picture where we have then destruction of cells, we start to see that pseudomembrane developing that is covering the area. We have then the congestion of all of those cells that are trying to help. But unless we are addressing the organism itself, that destruction will continue. And then this is when we begin to see a serious disease that puts the patient's life at risk. And if intervention is not done adequately and promptly, then we see all of the negative outcomes that impact our patients. Now, if we think about, what needs to happen, well, just one look at this cartoon shows you, how do we protect the colon? How do we protect then the gut microbiome to the extent possible, and either stop introduction of C. difficile as an organism, or how do we stop allowing it to become a primary player? So I want to stop at this point, and I think we have a polling question, and while that's up, then this is part of my family, and the reason why I'm looking at this problem, how do we prevent this from occurring, because it can impact all of us. So I want to look then at our first question, and that if we know testing for C. difficile is important, the question is, if testing is important, testing for C. diff is important even if the patient is without symptoms, so the organism can be treated and infection prevented. Do you think this is true, or is this false? So I want to stop and get some time to answer this. And clearly this is great, that we know that this is false, that we need to have a purpose, a reason for testing. And this is where we begin to think about that whole idea of our approach toward diagnostic stewardship. So I'm going to close that question and then hold on for that second one till we get a little bit later in our presentation. So diagnostic stewardship is a new term that you may be hearing and reading more and more about. And it recognizes then that we need to be intentional about testing, about our diagnostic interventions. So the presence of C. diff, the organism, in a stool specimen does not mean that infection is present. It means the organism is present. And therefore, when we use testing and which tests we use to identify the organism may lead us down a pathway where we feel like we have to treat. So if you have a patient that you test for C. difficile, the organism, and the organism is present, what is your approach in your healthcare facility? Are these patients who are automatically treated? Well, then if that is so, if we've identified the organism, we have to assume that the organism was identified because we are concerned about the presence of infection. Well, this is why in labs we say we don't test formed stool, because a patient with formed stool is not the patient that we are going to have that clinical suspicion of C. difficile infection. So we need to make sure that our criteria for testing is solid. We also need to be able to determine the clinical relevance of the results, because remember, no test provides 100% accuracy. So we have to have then good thought about, am I testing the patient appropriately? Can I trust the results? And then what do I do with the results once I have them? So when we test, that then will prompt our action. So you can see if our process of determining when to test is flawed, it may lead to an action where we have no choice other than to treat the patient. So this is kind of where that tension is developed. When do we test? When not to test? And what to do when results are negative, but maybe C. difficile is still C. difficile infection, CDI is still suspected. So we need to have then a firm grasp upon what is happening with this organism, what is a patient presentation, when do we prompt the testing, what do we do with the results, And then we need to be also thinking about, what is this entire spectrum of disease? Maybe we have patients that have very few symptoms other than incidents of diarrhea, but maybe they don't have an elevated white count. Maybe they are not expressing abdominal pain. Maybe that their chief complaint is just diarrhea. Well, we don't understand the full spectrum. Perhaps we have some individuals that have positive C. difficile, the organism. Yes, they demonstrate symptoms, but they may be able to recover without treatment. This is part of the spectrum that we are still trying to understand. We do know, though, that nursing documentation plays a critical point in this whole process. So we are trying to make sure that nursing as a profession and nursing assistants understand their role in helping us understand the scope of the disease and their role in diagnostic stewardship. I put this slide up just to show that in our studies in Louisville, we have 3 different testing algorithms that are used by hospitals in Louisville to help provide a report that indicates that the C. difficile test is positive or negative. I bring this up not so everybody can become an expert in microbiology, but to become expert in understanding where the problems are. That we also have attention now in our hospitals that if hospitals identify a patient with C. difficile and it was not, quote, present on admission, then the hospital has to claim that infection and may subsequently be penalized. Therefore, there is a lot of activity going on, number one, to determine when do we test, and secondly, how do we evaluate the various tests that we have to make a determination about whether or not this represents a positive or a negative test for C. difficile. So the struggle is in adequately identifying patients, making sure that we don't prompt what we currently see on occasion, and that is we may have a provider that is under intense pressure to not test, or at least they perceive pressure to not test. So we may be having them treat a patient for C. difficile infection without a laboratory result. So we have then a lot of individuals who are trying to figure out this problem, and we are all trying to do the best that we can for patient safety and patient outcomes, but there are still then many challenges. A number of hospitals have developed or adopted various algorithms to help them determine when do they test for C. difficile. Do we avoid testing on patients who have been on a laxative? Well, how do we gather that information? Well, many times it's from the patient themselves. Well, how are we asking the question? And how do we define laxative use? Is it someone who used milk of magnesia a day before, or is it someone who takes this daily? Is this someone who normally has loose stools that is part of their own physical presentation? How are we helping patients to give us the information so we can then make decisions about when testing is necessary and perhaps when it is not? All we know is that we want to avoid testing unless we are convinced that C. difficile infection may truly be present. So keeping an eye on appropriate use of testing. We've learned in our own studies that nursing documentation has raised a lot of questions, because when we talk with nurses, many people, and you may find this in your own groups, that somebody will describe one loose stool event as diarrhea. They may say, well, I had diarrhea this morning, and they really mean they had one loose stool event, whereas we know the actual definition of diarrhea is 3 or more liquid stools in a 24-hour period. How do we then document that? How do we evaluate it? How do our electronic medical record systems enable this? Do we have then the option of documenting a single loose stool event, or is diarrhea one of the options, either a stool or diarrhea, meaning that when you click on or select that, you are actually documenting a loose stool event. So trying to get our arms around nursing documentation and our arms around our electronic medical record systems and see what role that's playing. Also, how do people evaluate a stool? We know that the Bristol stool chart is taking on more and more a popular approach in helping people make decisions on how they characterize stool, so that we have then some objectivity across documentation. We do know that there are a number of factors, looking at the epidemiology of C. difficile, a number of risk factors. We know exposure to antimicrobials is certainly a risk factor. If you acquired the organism, the C. difficile organism itself, that is a risk factor for going on to develop infection. We know that advanced age or underlying illness or immunosuppression, anything that is causing then or resulting in a faltering of our immune system is a problem. Individuals who are on tube feedings, we prepare them the tube feedings, perhaps then with hands that have not been cleaned or equipment that has not been cleaned, and then we deliver food via a feeding tube and deposit then that food beyond the gastric acid. So feeding tubes typically, the tip ends beyond the stomach itself. And so we have bypassed then the protective effects of our gastric acid, and then we enable the individual to become ill just from the tube feeds themselves and the processes in preparation and administration. We also then have the taking any of the gastric acid suppressions, suppressive agents that again, remove then the ability for our gastric acid to protect us. There's some things that we don't know or we don't understand. We don't understand colonization in the population. We don't understand C. diff acquisition when there is no recognized healthcare contact. We also don't have a firm understanding about recurrent disease and what happens to individuals once they have primary illness, and then who is at greater risk and what may impact and perhaps support recurrent disease. We don't then have a full understanding about diet on acquisition and diet as a disease reoccurrence as well. So still so much to learn. What we do know is that we have fecal oral transmission. We have an environmental reservoir, a number of environmental reservoirs. Hand contamination is certainly an issue. The fact that we have a misunderstanding about how to either evaluate our laboratory results or how we evaluate acquisition and when infection results. We do know that treatment has to be confined to those with CDI, that is infection, and not necessarily those with C. diff infection or just the presence of the organism itself. So still a lot for us to use with what we do know and how we make a difference. We do know that there are important implications between infection control interventions and C. difficile infection, and that is, of course, diagnostic stewardship, how we identify and when we identify the organism, and how accurate our identification methods are. We do know that it is important from an infection prevention and control perspective to recognize the difference between infection and just presence of the organism itself. How we implement isolation and how we do that consistently, reliably, and effectively, and how do we deal with what we're all hearing now, isolation fatigue. That's a huge problem. Again, stewardship in terms of do we treat or not treat. Environmental infection control, I think, is a huge aspect, and I know one of our areas of interest specifically today, and how we understand the role of the environment and what that means. Hand hygiene, and then clearly looking at our patient care processes and recognizing opportunities for this fecal oral transmission pathway to occur. So it's making us look at our care practices. If we look at these just quickly, each one of these together, we know that many of us are relying on a testing algorithm. There are a number of flaws in that algorithm. So just like it brings strength, it also brings weakness. And anytime we look at anything that is going to guide our decision making, we need to be just as attentive to its weaknesses as to its strengths. Again, making sure that we have firm definitions in our algorithms. So if we are are looking at excluding patients with a history of laxative use from testing, we're not recognizing then the ability for an individual who is on laxatives to also have infection with c. difficile. So we may fail to identify these patients. If we fail to identify them, not only can we not treat them, but we can't prevent them from being involved in transmission through environmental contamination. We've got to make sure that we can adequately and accurately identify when diarrhea is present, and then make sure that we have a way to document both its presence, but also not document when it isn't present. If we document inappropriately, then that poor documentation may actually be driving testing. Well, what happens when we have a positive test? Well, making sure that we understand that there's a clear difference between identifying C. diff, the organism, and identifying C. diff, the organism, in a symptomatic patient. That's what makes C. difficile infection. That then helps us begin to make some decisions about when do we isolate or when do we not isolate. If we test and we identify C. diff in a patient without infection, we may feel compelled to isolate that individual. We all know isolation has its own set of issues. Patients then have been demonstrated in some studies to be more likely to have care errors when they are in isolation. So we don't want to isolate patients when they don't need to. If we have confusion about identifying the organism, then we may have confusion about identifying acquisition opportunities and the relationship to future transmission. So being very careful in not only identifying the organism through testing, but figuring out what to do about it is quite problematic. But we do know any patient with C. diff is a potential risk in terms of environmental contamination and environmental infection control, and common practices such as hand touching and then hand contamination. So we need to know our patients who are infected. Let's know these patients so that we can establish then very firm interventions with them. If we isolate, are we contributing to isolation fatigue? But if we expect isolation practices, then all of our staff need to be educated. Our patient and family members need to also be educated about what it means when someone is in isolation. We need to recognize everybody's responsibility and environmental contamination. And then do we have the ability to think about environmental infection control so that we are recognizing the importance of this microorganism in our plans for patient safety? When we isolate, are we clear about what we're accomplishing? If we are isolating patients, and we need to know how well we're doing, so having the ability to evaluate how well or how poorly staff are doing, and then using that information to retrain. Antimicrobial stewardship, I know, is on everybody's radar. Not only use of antibiotics, but the whole notion of let's not use them when we don't need them, but let's not test for organisms when the need is not there. So unnecessary testing of patients, because those, once you have a positive C. diff test, then that may be driving treatment, which may be inappropriate. So that whole notion that if we document diarrhea appropriately, both its presence and its absence, that will have a tremendous impact on when we are ordering testing. We also need to be thinking and talking with our patients about recurrence, having them, and all of us have dealt with patients with C. difficile infection, and we know that it's a miserable disease for patients. They are very fearful about recurrence. We need to talk with them that once you have had C. difficile infection, your stool has changed. It may take quite a while before you return to normal, if ever returns to your quote normal or your baseline. So how do we help them understand recurrence and what to do when they are concerned about disease again? We may need to spend time with them about future antibiotic use, and that if you do take antibiotics again, you may be then at risk for developing C. difficile again, a new onset of disease associated with antibiotic use. So a lot of time spent in patient and family education. probably the biggest thing that has become on our radar is looking at environmental infection control. And I really think that we have disinfectant stewardship that is just as important as antimicrobial stewardship. We need to make sure that we're kind of approaching this with the same 5 rights that we approach in an antibiotic or medication administration. We need to make sure it's the right agent and that we are using it correctly. We are dosing it correctly. We are administering or applying it correctly. We have the correct duration or contact time. So looking at our use of a disinfectant process we know is in need of attention. And this is not an issue that belongs to one department or another. This is a collaboration that must be present between environmental services, infection control, nursing as those that are providing care, and others, so that we are assured of an adequate process of environmental disinfection. We also need to make sure we're keeping an eye on new agents that are coming to market. I know Dan briefly mentioned the NADCC tablets or the hypochlorous acid solutions that we are seeing more and more of, and making sure then that we have a process for evaluating the use of that within our facilities. We're also then looking at adjunctive technologies, and I think many of you may already be looking at UV or self-disinfecting surfaces and trying to determine their role in our facility, both in terms of their effectiveness, but how well are they able to be used within our care practices. So environmental infection control, I think, is a huge area for all of us. So let me stop at this point, and this is a picture of my team, at least a part of my team here at the University of Louisville. And if we can pull up, Dan, the second polling question, if we have those results or information that we can share. Good. I think we may, can we ask people to respond again so I can make sure that we're looking at this? The second question, according to current guidelines, environmental disinfection should employ use of a sporicidal agent only once an outbreak of C. difficile has been identified. Do you think this is true, or do you think this is false? Perfect. I think many of you see that this is false, that we do not need to wait to use a sporicidal agent until we have an outbreak, that more and more of our facilities are saying, you know, we're using a sporicidal agent much more frequently. Some are using that as their standard germicidal agent. So I think just the idea that we need to have a sporicide firmly entrenched in our environmental disinfection practices, because we don't want to wait until we need something before we practice incorporating it. So if you're like me, we have problems. If I'm going to have a big problem, it always seems like it's going to be Friday, or when we have a holiday, or maybe, you know, when I'm trying to get ready to go on vacation, and all of a sudden I'm trying to change practice then. Well, don't wait until that time. That we need to make sure that your environmental services department is well equipped to begin to think about the building as the new patient. That our patient has a respiratory system, that's our ventilation. They have a circulatory system, that is the water. We have a GI system, that is how we manage waste. And we have a skin or an integument to our building. And these are our surfaces and our equipment. So we've got to think about our building as our new patient, our healthcare facility as our new patient, and be thinking about all of these systems as they relate to environmental care. Now, hand hygiene, we all know, is critical. A common sense approach is, if your hands are visibly soiled, then soap and water as a hand wash, and then use alcohol-based hand rub as an adjunct. Keep in mind, you know, use a common sense approach. If patients have C. difficile infection, then diarrhea is present, and opportunity for hand contamination is present. So please don't obsess over whether I use hand washing or whether I use alcohol-based hand rub. Assume that your hands are going to be soiled, so wash them. If you have access to soap and water, use it. This means after you remove your gloves. If you don't have immediate access to soap and water, then don't be afraid to use an alcohol-based hand rub. The idea is, keep your hands clean, use what methods you have available, and make sure that, above all, you are building a consistent, reliable, valid, reproducible process for keeping your hands clean at all times, and then thinking whether we're thinking about the 5 moments or we're thinking about every time we touch a patient. But also, please remember, the environment is an extension of the patient. So when you touch the environment, then you have hand contamination opportunities. Therefore, you need to have hand decontamination opportunities available just as readily. We need to be thinking about how care is delivered and what are those opportunities that enable us to contaminate anything that is going to go into the patient's mouth with stool. So what am I contaminated? Is it if I'm giving them oral medication and it's coming in contact with my hands? That is an opportunity for me to contaminate oral medication with organisms that may be on my hands. The patient's environment that the patient will touch, and then they put their own hands in their mouth. Maybe our oral care practices, not only toothbrushes, but oral suctions, anything that is going to go in that patient's mouth, we need to be looking at as a vehicle for this microorganism. So thinking about how these items come in contact with the environment, how they come in contact with hands, and then what we need to do to block that transmission. We know that we're also looking at the impact of antibiotics in food. So it's not only what is happening in the actual healthcare environment, but this is a bigger picture that we are still trying to understand. And so I'm not suggesting that, we only let our patients have peanut butter and crackers, but I'm recognizing the fact that C. difficile, the organism C. difficile infection, still continues to be a major problem, in understanding what is happening in the community impacts what happens in our facilities. So again, we go back to C. difficile and infection control. We need to have some processes in place where we isolate diarrhea of unknown etiology until we figure out what's causing it. When we have C. difficile infection, we isolate until the diarrhea resolves, and then we consider thinking about continuing isolation for another day or two as the actual burden of the organism is reduced in their colon, and therefore the organism, the ability then to contaminate the environment may be reduced. Continuing to stress our understanding of practices regarding environmental cleaning, and then thinking about how we incorporate then these sporicidal agents so we can further minimize the organism in the environment. Hand hygiene, and then of course, as I mentioned, always including our patients and family in our education. I put this this fishbone diagram not as something that we're going to go through today, but just to stress the fact that when we are addressing C. difficile, this is not a simple problem. This is a complex problem that requires that you pull together individuals within your facility as everybody is focused on improving care and changing practice. This is not a one person show. This requires that you have then the way to pull together both individuals in your organization, but also think about our industry partners. They are bringing in new ideas, innovation to the workplace. So reaching out to them and including them as part of your solution is important. As I mentioned, I want to make sure that you have references available that you can go back. The one at the bottom, the paper by Mara and colleagues is written, and I think that is one that has just come out, and I think is a really great overview of what is in the literature, a systematic review and meta-analysis. This is providing then some new information for us and some new insights, and it's just a reminder that new information is constantly coming out about C. difficile. So if we're going to address this, we need to have an eye toward what is happening in the literature. So with that, I will turn it back over then to Christine so we can begin to take a look at some of your questions.
Thank you, Ruth. This is very excellent, very informative. I know I learned, I always learn from you. So thank you very, very much. We do have some questions that have come in, and let me begin with those. One moment. All right, so Ruth also had it. Oh, go ahead.
Nobody should have to look at my desktop. It's sort of like looking in my purse. I don't know, it's an ugly sight.
Uh, I have, I'm going to start with the questions here. There's one posted by Chantal, and it states, what is the latest on the role of CDI for patients with Crohn's disease? These patients are immunocompromised and on acid reducers, but often the stool test comes back negative. However, clinical signs, despite routine Crohn's disease treatment, is not controlled. Could they benefit from CDI treatment to check for improvement? Yeah, go ahead.
This is a huge, and this is a clinical question that you know, I know that's far beyond our ability to address today. But I think that the issue that you bring up is germane, that we have individuals that have a clinical presentation that causes us to scratch our heads. Yes, they are immune compromised. Yes, they will have presence of diarrhea. Yes, they are on an acid reducer, so they have lots of risk factors, yet we haven't identified the organism. So I think we look at our testing methodologies, but clinical practice is always going to have these types of challenges. But perhaps they could benefit from treatment, but only if they have the disease. And I think we're hesitant to provide treatment for anyone where disease is not present. But again, that's going to be according to guideline. But as my boss often tells me, Ruth, remember that everything we know about healthcare is little bitty compared to what there is to know. But in this circumstance, you're going to go with your clinical guidelines, but testing methodologies are always going to be a challenge in how they're evaluated within the laboratory setting.
Thank you. So unfortunately, I just got kicked off. So luckily, I am dialed in with my phone.
Okay.
Ruth, are you able to see the next question in queue?
I can. So we've got a question about the use of routine probiotics. And I know there's a lot studying now about, you know, what is the benefit of probiotics. And for every paper, it seems, that I read that says there is a benefit, I will turn right back around and read another one that says there's no evidence. You know, and I think, you know, keep in mind, we have, you know, thousands of organisms in the gut, many we don't even know about. And we're replacing one or a handful with probiotics. So there still is a lot for us to learn. But one thing that we do know is that we never, at least I never thought about a stool being part of my immune system. But we're learning that it certainly is. So how we manage the maintenance of our own body's microbiome is critically important. So I know that the use of probiotics and different dietary supplements are certainly under review and of tremendous research interest. But again, I think we're going to have some pretty big studies. It's hard to design those so that you've got statistical power. So it is quite a challenge, but I think we have a number of new approaches to understanding the microbiome that are going to be able to give us at least some additional answer where we feel like we've got good validity. I think we've got another question where there's new data that shows asymptomatic C. diff carriers versus CDI patients have as much or more shedding of the spores. And that, we are seeing that once you have the organism, it's all over the place. Now, the problem is not all C. difficile is the same. So we know that we have some C. difficile organisms that are not toxin producers. Well, will they always be a non-toxin producer? Or what does that impact? So, you know, we are trying to get our arms around an understanding of C. difficile, the organism. I think one question was, well, you know, what happens when you find spores on the floor? You know, again, I'm thinking about the floors last. I want people to clean the surfaces I'm going to touch a lot. And, you know, we don't have a 5-second rule in hospitals. You know, once it hits the floor, it should be discarded. Yes, I know our floors are contaminated. There's a lot more stuff on them than C. difficile. But it's almost like when somebody is saying, well, I'm worried about, you know, washing your tie or, you know, washing your lab coat. And I'm like, quit distracting me. The big ticket item is washing your hands. The big ticket item with the environment is, environmental infection control on surfaces that we come in contact all the time. So, don't get pulled away from the big issue. Once we solve the big issues, then I'll be thinking about the floor. But that is nowhere on my radar at this point in time, although I certainly recognize that the floors are dirty. A couple of questions. Will we share slides? I have absolutely no problem with sharing slides. If you're going to be an evangelist for infection control, I want to support you. I'm all about it. I'm all about it. Another question, home care and disinfection, homeowners insurance. I'm probably not going to be able to address those types of questions. Copper infused self-sanitizing surfaces. Again, we know that the self-disinfecting surfaces are coming under more and more scrutiny. I'm again interested in removing the organism from the surface, and I know I'm not going to be able to have a complete silver impregnated surface or copper impregnated surface or complete copper surface. Although I have to tell that company that I love their copper commode. I think that's one of the that I think is one of my favorite displays now. It kind of looks like it gives a new approach to a copper throne. So I got to hand it to them on the display. But I think that there are a lot of benefits to bringing in new types of surfaces. But again, I want us to really focus on what are the basics of practice, and nothing is going to take the place of removing the burden of the organism off of surfaces. We're going to have consistent approaches, and then we may be able to be augmented by self-disinfecting surfaces. But I don't want us to spend time thinking about what may happen in the future. I want us to spend time about thinking about what do we need to do at the present, and then ensuring that we have a strong environmental infection control. Somebody mentioned about surfaces matter, but when a caregiver moves through the room and everything gets aerosolized, yes, certainly we know that there is movement of microorganisms as people move through. But I don't think anyone's research has said that cleanliness of the floor is as important as routine cleanliness of an environmental surface. And I know as we move through the floor, if I'm going to reduce the burden on the floor, the amount of people that are moving through continuously, if I'm kind of following that logic, I'm going to have someone that is cleaning the floor continuously. In the process of cleaning the floor also, promotes aerosolization of microorganisms. So again, I'm not going to say, please give more attention to the floor than the environmental surfaces. I'm going to say, let's figure out what's happening on the environmental surfaces. But to your point, I think our environmental guidelines have said we can just use regular soap and water on floors, that perhaps we're looking at, do we need to have a disinfectant on the floors? If so, we've got to begin to think about, the complete impact of chemicals on the floor, and then what is that doing to materials and our floor maintenance. And so, it's a big issue, not just one about whether or not we want to disinfect floors. So I hope that kind of answers that, at least in an initial way. Well, I know that we've talked and covered quite a bit, and if I can just kind of summarize where I hope that this discussion takes us, that there are big ticket items. Number one, an environmental infection control program that is comprehensive is critical. And it's one that everybody needs to buy into. And it means that we need to recognize the individuals that are doing that work. Our environmental services personnel, we need to show them some love. We need to recognize their profound importance in this event. So please don't think that one environmental services person can take care of an entire patient care area, and let's not show them the disrespect by kind of tossing things at a trash can instead of putting it in. Everybody's got a role in maintaining a clean environment, but everybody needs to know how to disinfect. Number two, make sure that people are armed with appropriate disinfection capabilities. So this means we've got to have a combination of products available to us. We need to be on the lookout and know what's on the horizon, what is industry bringing in new to the table so that we can evaluate. Making sure that our documentation is driving good use of clinical testing. If a patient doesn't have diarrhea, then we need to be giving some serious consideration about whether or not we test. Also, every patient that has diarrhea, we need to evaluate to determine is testing appropriate for that individual. And then we need to include our not only our staff in education, but our patients and patient families as well. So I think that this leads to the recognition that addressing C. difficile is not an easy issue. This is a very complicated and a very complex problem that is going to have to take all of us working together in a unified manner addressing this. Please remember that this patient with C. difficile can be you. It can be anybody in your family at any point when all the holes in that cheese line up. So there needs to be personal engagement and personal commitment as well as professional commitment to keeping this from happening. So with that, let me kind of close out the Q&A session and turn it back then to you, Christine, for any closing.
Thank you, Ruth. And thank you you got through all the questions. Excellent job. I also want to thank everyone in the webinar, those of you who are with us via either your phones or with your laptops. Thank you all for joining us today. Look forward to seeing all of you next week on Tuesday. In your email, you will have an email from infectioncontrol.tips. It's Michael Diamond from infectioncontrol.tips. He has a link to a survey that you'll need to complete for your 1 credit, educational credit. Everyone, if you're watching this as a group, make sure that everyone in your group has access to that link. Next week on Tuesday, we will hear from Dr. Marcia Ryder. I look forward to being with all of you again next week. Our 3rd webinar will be the following Wednesday. That will be my presentation. And again, don't forget to click on the link for your continuing education credits. And again, thank you, everyone. And that closes us up for today.
All right, very good.
Thank you, Ruth.
Thank you very much. Thanks, Dan.
Great job.
All right, very
Thank
good.
you, Ruth. You are fantastic. Bye, everyone.
All right, bye-bye.
Bye.
Bye-bye.